sư Angela Chong từ Singapore sẽ giới thiệu chúng ta một cái chủ đề rất là có tế bào học của tuyến tụy mạch. I would like to invite Professor Angela Chong from Singapore to give a talk about the pancreatic and the cytology. Please.
Thank you, everybody. I'm not an expert, but it's good to share, and I would like to share my cases with you so that you can see that experience is not only about making the correct diagnosis, but experience is also making a mistake and learning from your mistake. So, as I said, thank you very much to all the organizers for allowing me to come here. Vietnam is a very exciting place, and it's one of the fastest developing economies of Asia. So, without further ado, please let me share with you my adventures in pancreatic and biliary cytology. So, thank you to the 14th meeting of the Pathology Society of South Vietnam. The traditional zones of comfort for us when we are practicing cytopathology are the 4 or 5 different categories. And when we do cytology audits in the laboratory, these are the things we look for. Non-diagnostic, we are always very happy. Why? Because we don't have to do anything. It's non-diagnostic. It's not my fault. There's nothing there. I don't need to say anything. Benign is a little bit of a problem because when they put a needle in, it's always in the investigation of an imaging mass or an imaging shadow. So there is something there that the clinician is looking for. And if we think it is benign, is it a benign entity? Is it infection, or is it normal histopathology, is normal cytology? In other words, the needle might have missed the lesion. So when you're saying benign in the old days, you have to be careful which category of benign. So the message you give to the clinician may be correct, it's benign, but it may be wrong because you did not tell the clinician that the needle missed the lesion. So there should always be a caveat. Then of course atypical is a problem. As you know, atypical can be in the eyes of the beholder. I say somebody is pretty and you might say somebody is not pretty. You might say something is atypical reactive, or you might say something is atypical suspicious for malignancy. So again, there's a wide range of atypical. Suspicious, again, suspicious for malignancy, almost 100% suspicious or suspicious of malignancy. It's a little bit more than atypical reactive, but I think it might be malignant, but I'm not sure I'll put it into suspicious. So that's the problem in the old days when we do audits, and it's a problem for the clinician because he or she, the clinician, may have a problem in when you are following clinical protocol. What is the protocol? For instance, now when you do the Bethesda thyroid cytology, the clinician wants to know which category so that then they can institute the standard institutional protocol. Whereas in the old days it was a little bit more loose and more ad hoc. So previously there was a Pancreatic Society or cytopathology system and how to use it. So basically there was a high sensitivity in the 6 or 7 categories. They did specify the different categories and tried to tie it in with histopathology. But I would like to point out that at the bottom of all this, a good communication is the bridge between confusion and chaos, or between confusion and clarity. So whereas previously, for instance, only in the breast did we emphasize the triple approach. The clinical diagnosis, the radiology, and the cytology have to match before you do anything, before you enact. Now, going in more countries, in more hospitals, into more organs, it is beholden upon us as psychopathologists again to emphasize to our friends the clinicians and our friends the oncologists that there should be clear communication between the laboratory, the surgeon, and the radiology department. And it is only then that we can get the full benefits of what the needle harvested. So the Pancreatic Society had, as you can see, 6 categories instead of our usual 5. It expanded a little bit. And there was a non-diagnostic, and there was a negative. And you note that in the negative, there's a lymphoepitheliosis, there is infection, and benign pancreatic parenchyma. And the clinical management will be conservative. When it's atypical, the recommendation would be conservative repeat of surgery. And in the neoplastic, there was a difference between lymphangioma, schwannoma, benign neoplasm, and a neoplastic other. For instance, the IPMN or the mucinous cystic neoplasia. And please note, neuroendocrine tumors at that time. And then of course, suspicious and positive. And of course, you know then that there was an emphasis on the ancillary testing. So I've lived long enough. 40 years ago when we were when we had harvest from the needle of fluid, we brought it to the clinical chemist and they asked him, oh, please could you do the CEA for us because we wanted to know the cell yield was very low, so could we give an indication? And the clinical chemist did not want to do the CEA because he told us at that time there was no published data as to where to draw the cut-off line. Whereas now, it is taken for granted that you should send, you could send fluid for CEA, and it would help you. The WHO system not only has more categories, it has from 5 to 6 and now 7 categories, and it has rearranged a little bit. For instance, the insufficient, inadequate, or non-diagnostic categories were in what we used to call inadequate. So please note the non-diagnostic. In other words, your needle might have this benign or negative, and the atypical. So the clinical management would be to repeat the biopsy for 1 and 3. And if you think it's negative for malignancy, benign, but you have a lesion, better correlate. And then you have pancreatic low risk, pancreatic high, and suspicious for malignancy and malignant. So please note that in some hospitals there is a difference in the surgical management for suspicious, especially if your needle has gone into a pancreatic mass which looks malignant and you're calling it suspicious to about 80-100% confident, or if it is brushing from the biliary tree, please do reassess before you do anything drastic, because the biliary tree, usually the tissue is non-virgin. There's been inflammation, there's been some operative procedure, there's been some brushing, so that area is non-virgin, and that area can give you a false positive very easily. So the WHO system, repeat sampling, and of course ancillary testing for fish is available. So nowadays with the ancillary testing, it is highly recommended if it is available to you. So Pancreatic system versus the WHO system, the big difference is in the pre-malignant and low-grade malignant categories, and in the WHO it is the neoplastic is converted into 2 categories. One is low and one is high, and please remember that there are differences. So this is a table from the WHO. There has been a shift. For instance, serous cyst adenoma in the WHO is now under negative, whereas previously it was under benign. And I think for us, the big thing was the Pancreatic, which was under neoplasm, under benign. It is now into malignant. So if you, like me, were doing cytology audits in your laboratories and you're looking at correlating, there is if you're adopting different systems, you will see a difference in the audit. So just to be conscious of it. So this is what I use, and I would say that there are traffic lights which are red. If you think that fine needle aspirate from the pancreas or brushing from the biliary tree is benign, when on imaging there is a mass. And also if it's if you're using the old system of neoplastic benign or other, in the new system there is a low grade and high grade, where the high grade has a higher risk of malignancy and the low grade has a lower risk of malignancy. And the suspicious and positive will remain the same. So this is the new system, and it has a chapter 10 with management categories for each diagnostic categories. And they have tried to tie it to the visual digestive system tumors, hence the neuroendocrine leaping across different categories. So this is from a little bird in South America, so just to be careful. Again, to emphasize that sometimes the needle only goes into part of the mass. If you're lucky, the needle hits the mass in the pancreas. If you're unlucky, the needle misses the mass. So you just have to be careful. In the brushing in the biliary tree, the brushing, as I said, has a problem because most likely it is a non-virgin territory. There have been scopes going in and out, injuring the mucosa, so the mucosa is reactive. And there may be stents going in and out. So again, the mucosa is reactive, so just be careful. So this is a typical brushing. And the non-neoplastic, you can see the honeycomb factors, honeycomb architecture. This is a spyglass, which is useful for the clinician. They think they are taking out bits and pieces. Oh, it's working again. So the spyglass is good for the clinician, but it's very taxing for the pathologist. Because it's very small, and if the surgeon is a little bit rough, just a little bit rough, all that you will see is mashed cells and with a lot of handling artifact, and it's not of much use to us as morphologists. So this is one of the specimens we got from the spyglass. You can see there's a lot of crushed artifact, but we could call it carcinoma in this because it's invading. And this is what the clinician will see through his spyglass. So he's trying to fight that small thing. This is from South America. So in the insufficient benign atypical, as I said, non-diagnostic does not, if the non-diagnostic does not explain the mass lesion, whatever your laboratory is used to calling, whether you call it inadequate, insufficient, or non-diagnostic, there has to be communication to the surgeon that this is what you need, that the needle might have missed, so therefore you go back and repeat if necessary. But if you think that it's benign, it's okay. Again, benign, and the atypical or suspicious, again, communication is so important. And again, in meetings like this, when we talk to the different pathologists, we hope that amongst us there are one or two clinicians or radiologists around to hear our angst, or hear our worry. So, in the benign category, the WHO has put serous cyst adenoma and other schwannoma, where previously in the perpendicular it would be benign neoplastic. So this is not just benign. Pan low and pan high. Angle has biliary, pancreatic biliary neoplasm, and I will explain later. And high has the higher risk of malignancy. For instance, a benign cystic neoplasm of the pancreas, low, with low-grade dysplasia, and mucinous cystic neoplasia with high-grade dysplasia. But again, these lesions are very big. They can have high-grade dysplasia very focally, so sometimes the sampling may not be accurate. Ancillary testing now, more and more, when we put a needle in, we can send for testing. So if you have it available, please do send. And of course, last time when we first came, what do you mean you send the fine needle excess fluid for Eurovision? That's for urine, but actually that is a fish test, which tests for some genetic testing. So, but again, the caveat is that not everything, even malignant, not everything will show you these changes. So you still have to correlate. It's not given. Be careful of gastrointestinal contamination. So, pan high. This is treacherous, and the biliary intraepithelial neoplasia is treacherous. So you just have to be careful. You have to think of it, and you have to sample well. And I honestly did not understand what good sampling of a neoplastic lesion was, or if the MCN was, until we had one on the table. And it was a 15 centimeter MCN, and we took 68 blocks. We sampled the whole thing, and some of them were mega blocks. So, thorough sampling, because you can find focal, you can find invasive tumor in these. So, in pan high, we need cytopathology, but you also need assistance from the CAA and molecular diagnosis. But you do need that morphologic diagnosis. Biliary intraepithelial neoplasia, as I've said before, is treacherous. And if you can get a whole lot of people together, and you will find that there's a range of what they call mild atypical to severe atypical. So, suspicious, please avoid the false positive. And if you are not sure, please state. And you should try and state the differential. That means you can't just say atypical but suspicious for a specific category, because otherwise you are not focused and you may be calling what is reactive a tumor. So, in cytopathology, we have to be very sure of ourselves, or rather confident of ourselves, what is atypical. So, this is definitely unequivocally malignant, so we can call malignant. You can see nuclei, nuclear membrane, nucleoli, and the slight decisiveness. And again, just to be sure that we know that neuroendocrine tumor has crossed the border. Be careful of metastatic carcinoma. Again, if you're not sure, do your ancillary testing. And the laboratory and cytology audits may need changing. So, well, we'll go on to my cases. This is me in Antarctica. Case 1. There was a male with a dilatation of the biliary tree and enhancement, in the neural enhancement. So we had a mixture of benign, but fortunately for us, you can see this, which was definitely abnormal. But it doesn't mean that it's only on that we called. We also had other areas which we thought were unequivocally malignant. Loss of polarity, not the nuclear membrane, different thickness. the nucleoli, multiple nucleoli, the different sizes of the epithelial cells. A formation of acini. Some necrosis and cell debris. So we thought this was unequivocally malignant. You can see the nuclear membrane. And last time we used to say, what do you mean by the cell is atypical and the difference in nuclear membrane? So if you divide the cell into four, each four corners are different. So this is, if they're benign, usually you divide into four, it should be about the same. Again, the spyglass. So this is the case that the spyglass showed an adenocarcinoma. And at the resection, thank goodness, it was an adenocarcinoma. So my basic thoughts are, if you, on cytology, if we did not have that spyglass, perhaps we could have done a panel, at least if you are thinking of a tumor of that histogenesis, this would help you. Case 2 was a male 45 where we had a blockage at the bottom of the CBD, and this is the lesion. I'm not sure whether you can see it. Come down. Yeah, okay, so you can see again that the cells are abnormal, the nucleoli are present, there's loss of polarity, and there is a difference in the nuclear membrane thickness. Again, some necrosis, cell intricate, so we thought this was abnormal. This case had several specimens. Rare atypical cells in the ampulla, bound-up aspiration of low cellularity, bound-up Russian was reported by my colleague as malignant. I received the frozen section and the specimen, and to our horror, there was ulceration, extensive ulceration, because there was a stent. We could not find, despite passing almost the whole specimen, we couldn't find the invasion. So we were really upset. My colleague was upset, I was upset. My colleague had called adenocarcinoma, and I was upset because I could not find the carcinoma in the specimen. So after passing the whole thing, we found one little strip, which could account for the cells that we saw. Now, if I go back to the cells that I showed you just now, you will note that the nuclear membrane was rounded, and if I had drawn the four, if we had drawn at that time the four, divided into 4 quadrants, each quadrant would look almost the same. So even though the cells were of different sizes, there was a nucleolus, it was a bit irregular, there was a loss of polarity, it was basically like this. It's not as atypical as the obviously malignant, so that was the lesson we had. We perhaps should have called it severely atypical rather than be so confident that it was adenocarcinoma, especially papillary and other samples from the same patient, which we couldn't call. So just to say that really is non-virgin territory, you have to be careful about it, however confident you are at that time. So, in atypia, what do I mean? So, again, we have to be very, very confident in telling the clinician, I don't know. Because we as pathologists sometimes want to tell the clinician, yes, I know what it is, it's this. We want to play God. But as my lawyer friend has told us, you pathologists get into trouble because you want to play God. So therefore, you must be humble, tell the clinician, tell the radiologist, I think it is this, I'm not very sure, can you please help us out, can we discuss? case of my professor saying, yes, it is, and that's it, I'm gone. So sometimes the typical suspicious is what you see. I might see a little, in the first slide, not everybody would see the little head of the bird. If you're on a Friday evening, you're rushing to go home, see a show, see a coffee, have a bit of wine, you might not see the little bird. But others, on another day, or another way, perhaps you see it in another angle, you'll see the bird. So just be careful, especially deep-seated cytology. Case 3 was a male, 32, had gallstones, and there was a little lesion, so they put the lesion in. They thought initially it was going to be a pseudocyst because he had gallstones and all sorts of things, but it was a monotonous, rounded cells, rather dispersed. I would have been very tempted to call this neuroendocrine, except that nuclear didn't look neuroendocrine. So, male, 32, and a BQ. So this is a very interesting structure. So we looked at it, oh, it's very pretty, it looks like a pineapple. What is it? Doesn't it look like a pineapple? Multinucleated cell, what of cytoplasm? Coffee bean. So just to show you what's a coffee bean anyway. We think it's a solid pseudo-capillary neoplasm. Let me go back in my hand. Oh, it's not going back. Okay, it's not going back, it's going forward. So sorry for this. This was a solid pseudo-capillary neoplasm. And yeah, I'm not sure why I can't go back. Very worse and worse. Anyway, so now I have lost my track. The differential for solid pseudo-capillary neoplasm is of course the neuroendocrine tumor, and which now is in the malignant, and we know many cases, in fact, some of my colleagues who had an initial biopsy of a low-grade gastrinoma or a low-grade neuroendocrine tumor, and within 3 months or a year, it spread, and so it is unpredictable. So thankfully, it has changed completely. So I heard the discussion on the Pancreatic just now. I will not go into it further. So my fifth case is contributed by my colleague Liang, 65-year-old male with bloating. So he had, I think, quite a few enlarged lymph nodes, a large mass. So this is one example whereby there's a lot of contamination and there's a lot of handling afterward. But Liang was really good. I don't know how she did it. So a lot of cytology depends on the person who is doing the smearing. And my old mentor in cytology said, sometimes you feel like telling the surgeon that the slide was spread by her thumb, and it's not useful. But she found a few atypical cells at the edge. So when you look at these fragments, look at the edge, because sometimes the edge of the fragments will be nice looking cells, pretty cells that help you. So again, you see these rather nasty looking cells. And they fragment, and you see this lymphoid dirty background in the background. You can see in the background the fragments. So this little fragment should tell you that this is a lymphoma. But mixed with it, you see pancreatic tissue. So just you need to identify what is glandular and what is lesional. CD20, you can see a lot of handling artifact, but on CD20, keratin was negative. So she put up diagnosis suspicious for, and the recommendation is if you have any leftover fluid or you have pass another one, give it to the hematologist. Please can you do a flow for me? Then everybody is happy. So you have the ancillary test, use it, don't sit and wait. So this is the specimen that came out. It's a lymphoma. So you can understand why there was so much smearing artifact, because these cells are very fragile. CD20, BCL6, normal. So lymphoma involving the pancreas rarely may present as a solitary mass. And if it's primary pancreatic, usually they are easier. Cystic lesions, I have had a traumatic few months because you won't believe it, my daughter ended up with a 15 centimeter pancreatic cystic lesion. So that's how I know 15 centimeters turned out 68 blocks, because I didn't pass it, my friend passed it, but it was 68 blocks. I don't think the lab was very happy with us. Solid cystic, so there's a solid and a cystic, and the cystic differential is there. So in this case, Leanne's case, an 83-year-old female with a past history of CA breast, with an abrupt truncation of the ducts at the pancreatic body, suspicious for malignancy. So it was not secondary from the breast. It's very, very mucinous. And the other thing is the consistency of the mucin is important when you're doing cytology. Thick mucin or thin mucin. Thin mucin, you push towards the low grade. Thick mucin, it's better be careful. It might not be so low grade. This one had some cells, and the cells again not very pretty. They've lost the polarity. They're trying to tell us a story. And we were lucky in some. This was it happily gave up its cells. So it is one of these mucinous tumors. And she gave a list of differentials because in the fine needle you are unable to see the stroma, especially if it is a mucinous cystic neoplasm. So Pan law, just for illustration, I know we're running short of time. Pan law specific lesions would be, for instance, pancreatic intraepithelial neoplasia, biliary intraepithelial neoplasia, and mucinous cystic low grade. And in the high, it is again the higher grade of these, including mucinous cystic neoplasm, high grade, and tubular papillary neoplasm. And there is one caveat is that, but just be careful again of the biliary cystic thing. Ancillary test fluid, yes, please do send it out. Again, the consistency of the mucus is important if you are doing the aspiration. And there is CEA, and now, unlike 40 years ago, we have a little parameter there, and molecular studies. So this is the tumor from that patient. Very pretty case. Cytology was not so pretty. CDX2 intestinal type. So intraductal papillary mucinous neoplasm, and then depending on the histology, whether or not we find the patient. But on cytology, we stop there because we cannot see. This is my daughter's specimen. This was a 15 centimeter mucinous cystic neoplasm of the pancreas. And I did not, again, I emphasize, I never really understood what it meant by proper sampling until it was my own daughter. Proper sampling puzzled me, because most of it was low grade. parts of it, one tiny bits were high grade. And I thought there was invasion, but my colleague said, no, there's no invasion because there's no difference in the stroma. The stroma has not changed. So, yes, I'm not sure why we are changing so fast. Yeah, as you can see, most of it is low grade, but only in that area at the wall where you have a small little cyst was the focus of high grade. So if you are putting a needle in whether through the stomach into the you will most likely not be able to sample that area of high grade. So again, when you report the cytology, you can say what it is, but there's always a caveat that you may not be sampling. Just as an aside, other cystic lesions, they've got epithelial cysts, and then just to say that if you look, there are all the clues, but you may not trust their clues. So this is atypical cell squamous metaplasia. So sometimes you do see squamous metaplasia, then you have to think, is it a squamous cyst or is it a squamous cell carcinoma? Because squamous cell carcinomas tend to be cystic. So it was not. This was a squamous cell carcinoma. High-grade epithelial interview. So again, this was from my visit to Antarctica. And I'm sorry for rushing through, but again, thank you. And I'll just show you the problems that we had and my mistakes and the problems we had coming out of the mistakes. So I hope at least there's some exchange. Thank you very much.